Welcome back to the deep dive. Today, we're doing something a little different. Usually we take this wide-angle lens to a topic, the big sweeping trends. But today, we are zooming way in. We are stepping directly into the shoes of a high-level surgeon facing, well, the ultimate test.
That's right. We are decoding the mind of a consultant surgeon taking the FRCS exam. And for anyone who isn't in the medical world, that's the Fellowship of the Royal Colleges of Surgeons.
So this is the big one.
It's the gold standard. It really is the final boss battle of surgical training here.
Yeah.
You pass this, you are effectively a consultant. You're the one in charge.
And the source material we're digging into today is just fascinating. It's essentially a cheat sheet, a high-level training template called FRCS Oral Cavity Lesion, complete history template. But reading it, I realized it's not a checklist. It explicitly contrasts the wrong way to ask questions, which is sort of the med student level, with the right way, the consultant level.
And it really highlights this massive shift in mindset. When you're a student, you're a fact gatherer. You're just filling in boxes on a form. But this document shows that at the FRCS level, every single question you ask is actually a strategic surgical move.
Right.
You're not just taking a history. You are mentally planning the reconstruction. You're staging the cancer, and you're predicting survival rates before you even touch the patient.
That is exactly what blew my mind. I always thought a doctor asks, how are you or where do you live? Just to be polite.
Right, small talk.
But in this document, there are no throwaway lines. Everything is calculated. So let's unpack this. This surgical chess match. It starts with biodata. Basic stuff, right? Name, age, address.
You would think so. It looks pretty boring on paper.
But then I hit this question in the right column. Are you right or left-handed? And I just stopped. I thought, come on, surely that's just some small talk. Building rapport.
It is definitely not small talk. And honestly, this is one of those classic traps for the uninitiated. If you don't ask this in the exam, you might actually fail the station.
You're kidding. Why? Why does it matter which hand I write with if I have a sore in my mouth?
Because you have to think 3 steps ahead. If that sore in your mouth turns out to be a cancer that needs to be cut out, let's say a glossectomy, where we remove part of the tongue,
Okay.
we have to rebuild that part of your anatomy. We can't. You just can't stitch it shut. It would pull your face apart and you'd never speak or swallow again. So the most common way to reconstruct is with something called a free flap, specifically a radial forearm free flap.
Okay, break that down for me. A radial forearm free flap.
It's pretty much what it sounds like. We take a patch of skin, tissue, and blood vessels from your forearm, disconnect it completely, and then plumb it into the vessels in your neck to reconstruct your tongue. It's microsurgery.
That is intense. You're transplanting a part of the arm into the mouth.
We are. And here's the key. Surgeons always prefer to harvest that tissue from the non-dominant arm. You do not want to take skin and potentially mess with the sensation or tendon function of the hand your patient uses to write, to eat, to live.
So asking about handedness isn't politeness.
It's donor site selection. You're planning the harvest.
That's wild. You're already thinking about the reconstruction before you even looked in their mouth.
Precisely. And that same intensity, it carries over to age. The wrong way is just asking how old are you? The right way is asking for their date of birth and then mentally calculating it.
Is that just a legal thing? Making sure you've got the right patient?
It's partly for identity, sure, but in the surgical mind, age is a massive prognostic factor. The data shows that being over 60 significantly drops survival outcomes in oral cancer.
Oh.
It changes the whole risk profile, and it changes how aggressive you might be with a big reconstruction. A 90-year-old might not tolerate a 12-hour surgery like a 40-year-old would.
And then there's occupation. Again, I assume this was just making conversation.
Never. It's detective work. If they work outdoors, a farmer, a builder, you're immediately thinking about chronic UV sun exposure.
Lip cancer.
Points you right toward lip cancer. If they work with wood dust, you're thinking about nasal or sinus cancers. You're building an environmental exposure profile.
The source also had a note about ethnicity and cultural habits that seemed very specific. It mentioned asking about betel quid use.
Yes, this is absolutely crucial. In many South Asian communities, chewing betel quid or paein is common, and it's a massive risk factor for buccal mucosa cancer.
That's the inner cheek, right?
Exactly. So if you see a patient from that background, you have to ask about it specifically because it just changes your entire index of suspicion. It's a very aggressive carcinogen.
Okay, so we've established the background. Now we get to the scary part, the reason the patient is there. The document calls this the lesion, and it has this acronym, SCOTMA.
Right, sounds like a secret society, doesn't it? But it's site, color, outline, tenderness, mobility, and associated features.
The thing that stood out to me was the demand for precision. The wrong question is just, so where is it? But the right one is, can you point exactly where the ulcer is? Why that pinpoint accuracy?
Because in the mouth isn't a medical answer. The mouth has different zip codes, and they have very different property values, so to speak. A cancer on the tip of the tongue behaves very differently than one in the retromolar trigone.
The retro what now?
The retromolar trigone. It's that small triangular patch of gum right behind your back wisdom teeth.
Okay, I'm feeling it with my tongue right now. I'm sure you at home are probably doing the same thing.
And if a cancer lands there, it has a terrible prognosis. It sits right on top of the bone. It's very close to deep nerves. So if a patient points there, a surgeon's heart rate goes up. It implies early bone invasion.
So the subsite dictates the whole surgery.
Completely. And the document also talks about sizing. Not just asking if it's big, but explicitly suggesting using coins. A 10p versus a 1-pound coin.
That's a great visual anchor.
Patients are terrible at estimating centimeters, but everyone knows what a coin looks like. A lesion under 2 centimeters, roughly a 10p, is a T1 tumor. Over that, up to 4 centimeters, it's T2. You're literally staging the cancer in your head based on whether they say it's the size of a penny or a golf ball.
And then there's the feel of it. The document uses this word, induration. I had to look this up.
Induration is just the fancy medical word for hardness, but it's specific. It's not just firm. It feels like a button or a piece of gristle under the skin.
That's a bad sign.
It's a huge red flag. If an ulcer feels soft, it might just be trauma, you bit your cheek. But if it feels indurated, the document says there is a greater than 90% chance it's malignant.
90%, wow. That's terrifyingly high.
It is, and appearance matters too. Everyone worries about white patches, leukoplakia. But the source points out that red patches or ricroplakia are actually far more dangerous.
More dangerous than white patches.
A red patch is something like a 50% malignancy rate right out of the gate.
All right, let's move to the part that honestly gave me chills. It was under pain, but the expert analysis called it the silent alarms, this specific term. referred otalgia.
Oh, yes. This is a classic must-ask question. In an FRCS exam, if you miss this, you might just fail the whole station.
So explain this. The patient has a sore in their mouth. Why on earth are we asking if their ear hurts?
Because the nerves in the head and neck are all interconnected like a complex circuit board, specifically cranial nerves 9 and 10. They supply sensation to the back of the throat and the tongue, but they also supply sensation to the ear.
So the brain gets confused.
Exactly. It's a crossed wire. If a patient has a completely normal-looking ear, but complains of this deep shooting ear pain, it means that cancer in their mouth has invaded those nerves. It's sending a distress signal up the line.
And what does that mean for the cancer stage?
It's very bad news. It automatically bumps the cancer stage up to T2, T3, or even T4. It tells the surgeon this isn't some surface sore, it has roots deep in the nervous system.
Wow, so my ear hurts is a code red.
It's a scream for help from the nerves. And there's another one just like it, Vincent sign.
Yes, the numb chin syndrome.
It sounds like a pirate name, doesn't it?
Yeah.
But it's very serious. If a patient says their chin or their lower lip feels numb, like they've been to the dentist but the anesthesia never wore off,
Right.
it implies something very specific. It means the tumor has eaten into the mandible, the jawbone, and invaded the inferior alveolar nerve that runs inside it.
And that changes the surgery.
Completely. It means you can't just cut out the soft tissue. You have to perform a mandibulectomy. You have to saw out a segment of the jawbone. That numbness alone dictates the entire surgical plan.
It's incredible how much information is hidden in these seemingly random symptoms. Let's talk about function. The document mentions something called trismus,
Lockjaw.
and there's a simple test for it, the 3-finger test.
It's a quick and dirty way to measure the interincisal distance. A normal person can fit 3 of their own fingers vertically between their front teeth, about 35 to 40 millimeters.
I'll do it right now. Okay, barely 3 fingers. I'm safe.
Good to know. But if a patient can fit less than 2 fingers, that is a major warning sign. It suggests the tumor has spread into the pterygoid muscles.
And those are the deep chewing muscles, right?
That's right, the ones that control your jaw. If those muscles are invaded, the cancer is classified as T4B. That often means it's effectively inoperable, or it's going to require a massive, disfiguring surgery to clear,
Just from that one test.
just from asking them to open their mouth. And similarly, you ask them to stick their tongue out. If it deviates, if it points to one side, it means the hypoglossal nerve is paralyzed, the tumor's taken out the motor wiring.
Okay, we have to talk about the neck. The document says this is the single most important prognostic factor. Why is the neck so critical if the cancer is in the mouth?
Because the neck is the gateway to the rest of the body. You can have a nasty tumor in the mouth, but if it hasn't spread to the lymph nodes in the neck, you have a fighting chance.
But if it has spread,
If it has spread to the neck, what we call N-positive disease survival drops by 50% instantly.
wow, so how do they assess that? The document warns against just asking, do you have any lumps?
You don't have lumps.
Yeah.
And mumps is lazy is what a medical student asks. The right way is probing for details, location, size, and most importantly, fixation.
Fixation seems to be the really bad one. What does that mean exactly?
Imagine a lymph node is normally like a little grape under the skin. You can move it around. If a node feels fixed, it feels like it's glued to the skin or the muscle underneath. It doesn't move.
I think that means
It suggests extracapsular spread, that the cancer cells have burst through the shell of the lymph node and are now growing into the surrounding neck tissue. The jugular vein, the muscles, that is the worst possible prognosis for the neck.
let's pivot to the detective work. Risk factors. We all know smoking and drinking are bad, but this document gets so specific about the math.
It's not enough to ask, do you smoke? A surgeon thinks in pack years. You multiply packs per day by the years they've smoked. And there's a threshold mentioned in the source, 20 pack years. Above that, your risk skyrockets.
And the alcohol synergy.
This is fascinating and scary. It's not additive, it's multiplicative. Alcohol acts as a solvent. It physically thins the mucosal lining of the mouth.
Like a paint thinner.
Biologically, yes. It allows the carcinogens from the tobacco to penetrate deeper into the tissues. If you smoke and drink heavily, your risk isn't just double, it's something like 30 times higher.
30 times.
It's the perfect storm.
We touched on beetle quid, but there was a detail that really stuck with me. It said the location where they place the quid predicts the cancer site.
Absolutely. It's direct contact carcinogenesis. If a patient tucks the quid into their left lower cheek every day for 20 years, that is exactly where the tumor will grow. It's a map. And the document asks a horrifying follow-up.
Do you keep it in your mouth overnight?
Oh God, sleeping with it.
Yeah. And that means prolonged concentrated exposure while saliva production drops. It's like marinating the tissue in poison for 8 hours a night.
And then there's the sensitive topic, HPV.
Human papillomavirus.
Specifically strains 16 and 18. This has completely changed the landscape of head and neck cancer. It used to be old men who smoked and drank. Now we are seeing young, fit, non-smokers getting tonsil and tongue-based cancers.
And the source says this is the primary suspect for them.
70% of oropharyngeal cancers are now driven by HPV. So the consultant has to ask about sexual history, specifically oral sexual contact.
That's gotta be a tough transition. How is your ear pain, by the way?
It is awkward, but the document gives a script for it. I need to ask about sexual history as certain infections can increase cancer risk. You have to normalize it. And it's crucial because HPV-driven cancers actually respond better to treatment. It's a different disease.
That brings us to logistics, the past history section. This felt like the part where the surgeon is figuring out if the surgery is even possible.
It is. It's the feasibility study. You can diagnose the cancer, but can the patient survive the cure?
One big one was previous radiotherapy. Why does that matter?
Because you can only zap the same area so many times, the spinal cord has a lifetime dose limit. Exceed it, and you risk paralysis. So if they've had radiation 5 years ago, you often can't radiate them again. That takes a huge weapon off the table.
And then there was this question about stairs and who lives at home. It seems so domestic.
But remember that free flap we talked about?
Yeah, the reconstruction.
When you transplant that tissue, it's incredibly fragile. The patient needs absolute rest and 24/7 monitoring for the first 5 days. When they go home, they are weak. If they live alone in a 4th floor walk-up, you cannot safely discharge them.
So their housing status is a medical variable.
It's a surgical outcome variable. If they fall, the surgery is ruined. A homeless patient or an isolated elderly patient might require a completely different care plan. The surgeon is acting as a social worker here because the physiology demands it.
There was also a mention of bisphosphonates.
Ugh, the classic gotcha in the exam. These are bone-strengthening drugs for osteoporosis, but they alter bone metabolism. If you do surgery on the jaw of a patient on these drugs, the jawbone can basically die.
Die. Like actually rot.
Yes. It's called osteonecrosis of the jaw. The bone just rots away because it can't heal. It's a nightmare. So if they're on those drugs, you need a very specific plan before you even think about booking the operating theater.
It really emphasizes that you're not just treating a tumor, you're treating a whole person.
You treat the patient, not the x-ray.
So we've gathered all this info. The template ends with a consultant summary. It mentions a 90-second presentation.
This is the synthesis. You've spent 20 minutes asking about stairs and coins and numbchins, and now you have to distill it into a clinically precise snapshot. The document gives an example. This is a 60-year-old gentleman, 40-pack year smoker, presenting with a T4A N1M0 stage 4 SCC.
It sounds like a secret code.
It's the language of action. In those 2 sentences, you've told the team everything. The risks, the tumor size, the nerve involvement, the next status, and the likely surgical plan. It's concise, accurate, decisive. That's the consultant standard.
It's just so impressive. I mean, looking back at the wrong column. How old are you? Where does it hurt? It almost feels negligent now.
It's not negligent, it's just incomplete. It's the difference between seeing a car crash and investigating why it crashed. The FRCS surgeon is an investigator, a planner, and a realist all at once.
So what's the takeaway here for our listeners? I mean, most of us aren't sitting for the FRCS tomorrow.
I think the takeaway is realizing the sheer depth of thought that goes into these medical encounters. If a doctor asks you something that seems weird, like about your hand dominance or your stairs, answer it precisely. They're building a mental model of your survival.
And they're planning the reconstruction of your life, quite literally.
And there is one final concept from the source material that I want to leave everyone with. It's something called field cancerization.
Ooh, that sounds ominous.
It is. We tend to think of cancer as a distinct lump, right? A bad apple in a barrel. But in the oral cavity, especially with smoking and alcohol, the entire lining of the mouth has been bathed in carcinogens for decades.
So the damage isn't just where the tumor is.
Exactly. The source mentions looking for associated changes around the lesion. The idea is that the surrounding healthy-looking tissue might already be genetically damaged. It's primed to mutate.
It's a ticking clock.
It is, so cutting out the tumor might not be enough. And that's the scary question the surgeon has to wrestle with. How much of the healthy tissue is actually a future cancer waiting to happen? It challenges the very idea of clear margins.
That's why the follow-up has to be lifelong.
You're not just watching the scar, you're watching the whole field. It's a battle against the environment of the mouth itself.
Well, that is a sobering but fascinating thought to end on. The body keeps the score, and apparently, so does the lining of your mouth.
It certainly does.
Thank you so much for breaking this down with us. It's amazing to see the logic behind the checklist.
My pleasure. It's a glimpse into a very disciplined world.
And thank you to everyone listening to this deep dive. We'll catch you on the next one. Stay curious.